Thanks so much, Tracy, and howdy, everyone. I know it's almost lunchtime, so I'll be quickly, or after the meeting, so I'll be quick. But really excited to talk a little bit about some of these insights, and then chat later on today and this evening. So quickly about Ipsos, we're a global market research firm. So we do big patient experience projects down to public opinion and political polling. You name it, we use data to analyze it. We're actually sending drones out into Gaza and Ukraine and Lebanon to evaluate the infrastructure damage to roads, hospitals, schools, et cetera, and then reporting that to organizations like the World Bank so that they can reinvest and reconstruct. So we take data any way we can get it. In terms of patient experience, so coming from the Department of Veterans Affairs, where I got the opportunity to lead the Veterans Experience Office, where we use those quantitative and qualitative insights to really drive process change and service recovery and improvement. I get to come now to the support side, on the contract and vendor side, to do and support the Department of Defense and other organizations that are really driving that change and really talking about healthcare at scale. Loved some of the insights from this morning's panel. A lot of the survey discussion, a lot of the patient experience discussion, using data to make those changes and shape the constructed environment to shape the way that your parents are your patients probably, right? Are experiencing the lobby or parking, or using AI and telehealth. We'll talk about those things at a really high level, and then would love, like I said, to have follow-on conversations. So here's a little bit about our evaluation and experience practice. Don't want to go too far into the weeds. I'm a Marine veteran, so I like images more than words. I can't count past 5 because I have 5 fingers. So I'll keep it really simple for the rest of the presentation. So here are some of our big clients. So the Defense Health Agency and the Military Health System. It's one of the largest integrated health systems in the country. The Veterans Health Administration being the second largest integrated health system in the country. We also do some really neat work for CDC, albeit there's a lot of turmoil in that environment now, and so we're trying to navigate that, some of those changes in helping design better insights to inform how those clinical outcomes are achieved. And then, of course, some of our private sector health partners, some of whom I know are in the room, so I'd love to connect with y'all and talk about how we're working with some of your colleagues. So we use a really cool superpower called Knowledge Panel. It's essentially a research panel that has about 60,000 participants. That's 98% representative of the total US population. And as you can see, we have over 2,000 different variables. So we know everything about these folks, their income, where they live, if they live in a rural area versus a suburban area versus an urban area. We know their age, their gender, their race and ethnicity, what their favorite color is even sometimes. So it's really neat to be able to not only conduct a lot of our public opinion and political polling research on this panel, but also to delve into patient experience topics and what patients and what people actually think is most important in their patient journey. So we asked a few questions. So Tracy and I kind of shaped what we thought would be most resonant for a lot of y'all. And like I said, this is kind of high-level data that we asked just a few weeks ago, so it's pretty fresh. But I think the most important thing is, how can we delve into some of these insights by doing more qualitative ethnographic research, so one-on-one interviews or focus groups to really get at the heart of what matters most to patients. So transportation and security, not surprising to a lot of y'all, and we'll talk a little bit more about that in a couple of different slides here. But here's some of the high-level data that we were able to capture, and then we've published a lot of reports about this. And you can see, based on some of what folks are telling us, is how they're getting to the hospital, how they're getting to their clinic, how they're getting to their specialty care, and what those barriers may be. The more, as we talked about parking earlier in one of the panels, and as you probably guessed, parking is still king, queen, prince, duke, whatever you want to call it. Everybody drives. But you do see nuances when you look at the age of the population, when you look at the income of the population. Obviously, public transportation, caregiver rides, and not owning your own car play a massive role in this. So how do we design better experiences knowing that still a lot of people, especially over the next 20 years, will be driving cars, but could they be driving less? And how do you shape your construction planning, master planning around that if you need less parking or you need more access to public transport or you need more Uber and rideshare opportunities? Lobby experience. I know this came up earlier too, so this was something I was interested in diving into because we did a lot of studying around this at VA and lobbies at VA. I know we might have some VA colleagues in the room. I'd love to meet y'all too. They vary dramatically from VA clinic to hospital to across the country. Some have a really beautiful feel, and some feel like you're walking into something that was built in the 1930s, which it probably was. So I thought when you look at the race and ethnicity as a primary determinant, we found some really interesting data. And African American patients in particular find it like really important. And so I asked the team, I was like, do we need to rerun this just to make sure? And sure enough, like, you know, that we didn't oversample certain populations, whether that was African American patients or Hispanic patients or white patients. Sure enough, this came up as a really important issue. And then you can see age kind of play, kind of not a big variance in data, but how might we delve further into this? I'd love to host a focus group with each individual persona type or a mixture of these personas to really understand like what matters most in that lobby experience. But I thought this data would be particularly interesting to y'all as you're continuing to think about your patient personas and how you design that lobby experience. AI and telehealth, okay, we want to know a lot about that. That's going to be a major topic of conversation throughout this conference and for all conferences moving forward. And I thought it's very interesting that even given COVID and the experience we've had over the last 6 years where telehealth really ramped up, if we saw our usage rates at VA in particular, they just skyrocketed because we had to, because patients couldn't come in the front door and see their primary or specialty care providers. But people really do want to continue to come to the facility. And so you see that here in the data and how consistent it is with in-person care with the option of having telehealth care. So I thought that was a unique insight that even though we're in this wonderful period of like fantastic technology and better broadband service, even for more rural areas than ever before, it is still so important for what you all do in facility planning, construction management, and master planning for your facilities and your clinics. Ambient listening. So I know we've all kind of heard this at some of the healthcare and technology conferences. We've seen it in practice. If y'all haven't seen this in practice, it's super cool to go into the patient care setting and actually go through with a doc. And even if you're just, pretending, and it categorizes different, and it bucketizes how that conversation goes, and then makes those specific recommendations, prescriptions. It's so neat. But how comfortable are people really? And what does that level of comfort look like now? And what does it look like this time next year? Or maybe even in 6 months or 5 years from now when we have a different set of patient needs and patient personas that we're studying. So I thought it was super interesting, especially as we break it out once again demographically and really think about how that may apply to the patient personas that you serve day in and day out. So lack of trust. I think the major barrier here is lack of trust in AI and how that resonates with folks. And we see that across the board, and it's not surprising whatsoever. So the last question we asked is around sustainability. Once again, I had the team like kind of run this data. I'm like, this is super interesting. Are we oversampling certain populations? And the data came back again. Each of these different topics, whether you're looking at the high-level quantitative data when we're polling 2,500 people like we did for this, or 1,100 people like we did for other questions, vice all 60,000 in our research panel that's 98% representative of the US population. It doesn't give you every nuance. It doesn't give you every insight that you may need. So I think that's really where that qualitative ethnographic research, where you're going in there and you're using human-centered design to really better understand your patient population and asking these questions to further add to that nuance. But really thought this was interesting, especially when you look at age as a predeterminant and ethnicity as a predeterminant for what people put that value on sustainability, especially given the presentations earlier about the first electric hospital. That's really exciting, right? But how important is that when to the individual patient? So we have this really neat series where we use a lot of this public opinion data called Knowing the New in America, where brands, especially in the healthcare space, like better understand people's insights and how to better navigate this new America, especially with all these regulatory changes coming down the pike. So would love to talk with y'all about that throughout the rest of the conference. Would love to talk about quantitative data, qualitative data, market and social research, some of the stuff, some of the really neat stuff we get to do in the government and outside the government. But also just happy to take a couple questions because I was trying to be really fast, and I think I was really fast because this is a great high-level overview. I'd love to take a couple questions if we have time, Tracy. Looks,
We do have time. Does anybody have a question that they'd
I'm
like to
happy to
ask
go back
John?
to any data.
Oh,
Yeah,
perfect.
fire away.
Thank you for your patience.
Yeah, thanks. This is really interesting. What I wonder, though, right? Henry Ford said if he gave people what they wanted, he'd make faster horses. So one of our challenges is what people want, which is what your data is telling us. Should we be giving them what they want?
Yeah, I think well, it depends on, like we talked about budget and we talked about planning and like how do you prioritize? You know, this is a big discussion on the voice of the patient, voice of the customer that we always had with VA. Like having those insights available at the strategic planning table is really important to consider and then balance against the other priorities of the system's need. There is no mission without margin, right? As was said earlier. So I think that to answer that question, you really have to delve further in. So this is just a high-level scrape of, you know, a statistically significant sample of our research panel. Like doing one-on-one interviews you can glean hundreds of insights from 1 hour spending with you and me talking about your healthcare experience than I would ever glean from a 5 or 10 question survey, right? And I think that's the power of ethnographic research. That's the power of human-centered design, patient-centered design. But I do think it is incredibly important to have those patient insights at the table when you're making these strategic level discussions. So then you can say, well, what matters most to the patient, then what matters most to the system, and what makes the most sense. Yeah, fire away.
So you had the charts with basic percentages of some demographic information. I'm sure you do this, but do you have the information relative to those interaction effects or regression analysis to understand the influence of the different factors?
Yes, yeah, we can get pretty wicked with some of this data and slice and dice it any way you want, depending on what the budget is and depending on your sample size, depending on the number of questions you want to ask. We've done some really like big studies for like the Defense Health Agency where we really drill down and ask 5,000 patients. Like what do they, with 25 questions, and we incentivize them to take this survey in a range of different ages and ethnicity and gender to really understand what that access looks like for them. So we can get pretty crazy with it pretty quickly. Our senior statisticians are some of the best in the business, coming from academia, but also been in the private sector for many years. So that's what when I was in government and even before that, when I was in the private sector, I really never knew the power of these research panels until I got under the hood and really saw like how you can weaponize something like that to better understand how your system can navigate this or understand how your brand can change and make sure that you're resonating with the people that you're serving. So it depends on what type of data you're looking for. I guarantee that we'll be able to get it, and if not, then we'll just reprofile and ask those same individuals the question. Because we have those 2,200 data points, I'll go back to the knowledge panel. Boop, 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 boop. There we go. Because we have those 2,200 data points across each profile, we're able to like really understand, oh, well, if we can cut income versus rurality and access to broadband, like that could tell us a whole lot about what certain subject matter. So would love to talk more if you have time later. All right.
Yeah, Clayton Mitchell with Yale New Haven Health. On your sustainability slide, you know, I think that a lot of times the perceptions that we have of the community are driven by our own personal stereotypes, because that right there. I don't think most people would view the African American community as valuing sustainability. So that, in my mind, would it's a huge stereotype breaker, but it strikes to the type of service that we provide in those communities and whether we're really aligned with what the best intent of those communities is and where their values are. So
Yeah.
that's incredible data, I think, and I think that right now people are skeptical of data in a lot of ways, but it drives them to make decisions and don't want to get political, but Target's experiencing this right now.
Right. No, and that's why I really, when I saw this slide as well as the other slide around lobby experience, I I was shocked as well, and I that's where I really wanted to to delve into doing more in-depth qualitative interviews to better understand, even asking the panel participants who we know answered this question, like reaching out and say, hey, would you be interested in spending 30 minutes with us for this study? Because we have CVS Health or whoever commissioning it. I think that would be really interesting to better understand, especially as it relates to sustainability, or for big healthcare systems. So maybe not CVS Health, but for lobby experiences like that to me is like, okay, these are two totally different topics, but we see similar data points. And so how do we better understand the nuance behind some of the binary data that we see up here? But yeah, like breaking and changing the nomenclature. This is part of our Knowing the New America series too, is like, what terms resonate best with these panel participants, with these Americans, that it's so representative, as opposed to what are the terms that turn people off. And so we can delve further into that as well, as especially things are being more targeted now than ever. So thank you all so much. Would love to continue the conversation later, and happy to do two-step lessons during the Western, because I'm from Texas, so happy to help out with that too. Cheers, thanks.